Hello, welcome to the session of Transforming Healthcare in Africa, the experience of Movement Health on its digital journey. In this session, we'll learn of the opportunities of three interventions that are tackling different areas in the healthcare treatment pathway and how they can be meaningful to ensure that the healthcare gap is successfully covered with innovation. At Movement Health, we scale digital interventions to tackle chronic disease management. We know that the world is facing a triple crisis of equity, effectiveness, and efficiency. Inequity, because by 2030, 80% of the chronic disease burden will tackle low and middle income countries. Of efficiency, because as our fiscal budgets are under pressure and funding for healthcare is under strain, we see that our populations are living longer and therefore requiring more health services. And our effectiveness, because we are seeing that 1/3 of deaths are due to preventable causes. That's where we see a tremendous power of digital interventions as one of the most meaningful opportunities to respond to this triple crisis. Why is it so? Because digital health interventions do have the power to dematerialize. That means that you can do things instead of being in person or with physical interaction, with virtual interactions, and therefore reaching much more people in farther areas. Second, it has the power to demonetize, because things that were very expensive now can be done in much more cost-effective ways. Instead of having to travel to the health physician or having to hire people to have direct interactions, you can do that with chatbots, for example. And the third opportunity is that therefore when you dematerialize and you demonetize, then you can as well democratize, because things that were otherwise prohibitive for many of us now can be accessible. And we can see, for example, that in global telecommunications, right? How easy it is now with novel technologies to talk with people all over the world, which, just a decade ago was, prohibitive for many of us. We're going to focus on the experience of Movement Health in three fantastic experiences that have been run in Algeria, in Ghana, and in South Africa, with an interesting complementarity between different regions in North, West, and South Africa, but at the same time in three different areas of the health system, where it's in screening, in referral of primary healthcare, and in secondary healthcare, in areas like screening, to awareness for screening, which is the case that we're going to hear from Victoria in South Africa on cervical cancer, is screening to referral, which is the case in hypertension in Ghana that Anima Ajua is going to share with us, and in more efficient times to effective treatment, which is what we're going to hear from the cardiovascular experience in Algeria from Adam. So enough of the conversation. Let's start hearing about the learnings of Movement Health in Ghana. The floor is yours, Anima.
Thank you very much, Hector. Hello, everyone. It's a pleasure to be here. My name is Ajua Enima Ohene, and I'm happy to share with you the progress that's happening in Ghana. And the area that Movement Health Foundation we are focusing on in Ghana is empowering communities through data-driven pharmacy care. Next slide, please. I am going to share the story of how we got here, where we are currently in Ghana. So essentially, Movement Health, when we enter a country, what we seek to do is to engage local stakeholders to better understand the various issues pertaining in the country, and collectively work with the local stakeholders to come up with solutions to benefit everybody within the country. So for Ghana, we engaged a number of healthcare experts on the ground. We had a series of interviews. We had a series of roundtables where we engaged doctors, pharmacists, other healthcare professionals, leaderships of private health insurance organizations, and other private organizations as such, So with the various discussions, we narrowed down on primary healthcare and then also on NCDs. Essentially, we looked at primary healthcare because it is an area of focus right now for a lot of countries. And for NCDs as well, Hector did mention that currently globally, about a third of deaths is due to NCDs. So with NCD and also looking at primary healthcare, we narrowed further down to hypertension under NCDs. Essentially, it would be clear. We need to be clear to let you understand that currently in Ghana, we have at least 1 in 4 adults having hypertension, and they are not aware of it. Again, 1 in 4 adults have hypertension, and they are not aware of this. This is research that is out there, and it's quite worrying. Looking at primary healthcare, we narrowed down to pharmacies, retail pharmacies. And essentially in Ghana, and I think a lot of African countries, we have community pharmacies or the retail pharmacies being the first points of call for a lot of people. In Ghana, to be specific, pharmacies are all over the place, especially in urban and semi-urban areas. So we thought of marrying the 2 areas that we're looking at. That is primary healthcare pharmacies, and then NCDs looking at hypertension, how we could put the 2 together to solve a problem. So we did engage the Pharmacy Council because we're looking at the pharmacies. And we realized that the Pharmacy Council had already set up a digital solution called the NEP, which is the National E-Pharmacy Platform, currently being scaled across the country. What the NEP does is that it's in hospitals and it's in pharmacies. So typically when the prescription is generated from the hospital, it can be digitally sent to pharmacies. And it means that patients do not have to roam about looking for where they can purchase a medication or access medication, because the pharmacies will be able to identify the prescriptions in the pool, in the NEP, and then contact the patients. And so we decided as a foundation and together with the local stakeholders to ride on this existing tool that is in place, the NEP. We decided to create a referral pathway on this NEP. So this meant that when patients go into the community pharmacies, where they go to purchase medications or vitamins and other essentials, they can check their blood pressure over there. And when they do check their blood pressure, if there's an issue, if the blood pressure reading is high, the pharmacist can document the readings or the vitals on the NEP and refer the patient accordingly to the next level of care. It is worthy to note that pharmacists in Ghana are not required by law to intervene when the blood pressure is extremely high. They have to refer to the clinician to attend to the patient. So this process now has been structured such that patients their information can be captured appropriately and referred to the clinic. We expect that this project that we are doing together with our main stakeholder, which is the Pharmacy Council, we expect that to impact at least about 500,000 adults. Again, I mentioned that we have a lot of people having high blood pressure, considering it is silent. We think that a lot of people will benefit from this program as we would encourage screening. In the end, we expect that this would help to bring down mortality and morbidity because we are screening early. We are preventing complications that's to do with hypertension. And again, we are also going to make sure that we analyze the data that is being generated at the pharmacy end, make sense of it, share with policyholders to make the right decisions based on data that's available to them. Looking at a bigger picture, we expect that after this pilot, the lessons that we would learn, we'll use it to replicate in other NCD conditions within the country. Again, potentially other countries with similar jurisdictions should also be able to pick this platform and ride upon it and use this within their countries. So this is a picture of us engaging with the leadership of Pharmacy Council, and of course with Tisha Bootman, who is one of our board members during her visits in Ghana. The next slide, please. The next slide is going to show you excerpts of this tool that I'm talking about, the referral pathway on the NEP. So the first screenshot is just exhibiting what happens at the pharmacy. So the pharmacist is able to capture the patient's vitals, the blood pressure, the weight, any other risk factors that is relevant will be captured on the platform. So if the patient's reading is essentially higher, it means that the patient has to be referred. And so in referring the patient, a number of clinics in close proximity to the pharmacy will pop up. And the pharmacist can select any of the facilities in agreement with the patient and refer the patient to the facility. Next slide, please. Whilst this is going on, the patient receives a text message, which is shown on the left, at my left. So the patient would receive a text with a code and also with the name of the facility that they are going. At the hospital end or the hospital's interface, you would see that once the hospital staff open the application, they'll be able to see that a patient is pending with their vitals. So they can also assess the history of the patient and then continue with the due process, refer the patient or screen the patient further and refer the patient to the doctor. The next slide, please. So to rehash what I just discussed and the project and what we envisage, we expect that this project would help improve patient outcomes. Considering the fact that, again, hypertension is silent, we think that once we encourage screening, document appropriately and refer patients appropriately, we will be mitigating mortality cases and morbidities. Again, I did mention that pharmacies are currently all over the place in Accra. We have over 4,000 pharmacies, sorry, not just in Accra, in Ghana. In Ghana, we have about 4,000 pharmacies spread across the various regions. You would agree with me that it is not everyone who will be able to afford the blood pressure monitoring kit. And so if we have these tools available in the pharmacies, then it means that it is accessible by everyone to receive all these healthcare services. Again, this solution, we expect that it is going to improve the system's efficiencies and, of course, cost effectiveness. If we are mitigating the complications that's associated with hypertension, it means that the healthcare system is going to spend less in managing the healthcare. Essentially, if someone has hypertension and it is not managed, it comes with stroke and other cardiovascular events. Managing strokes become very expensive for the healthcare system. So once we are mitigating this, we expect that it will bring down the cost of healthcare in Ghana. The last point essentially was about integrating this whole digital solution. It is very much integrated into a lot of national digital solutions, making this project even more efficient, seamless for healthcare providers. This is the last slide showing the pilot phase. We have started it. We have started training pharmacies and clinics. So far, we've been able to engage about 4 hospitals and 3 pharmacies. They have been trained. We have encountered a few challenges, but these are issues that can easily be resolved, especially about the fact that this is a new approach. Adapting to change is usually difficult for everyone, but we are working with the staff and other stakeholders to make sure this is seamless. Our next steps, again, is also to ensure that we are roping in the patients, empowering them so that when they go into the pharmacies, they can request on their own to have their blood pressure checked and advised appropriately. I will end here and hand over to my colleague in South Africa. But before then, I would like to share a message. Hypertension is critical for everyone. It is closer than you think. I have a personal issue where I had a brother whom we lost in December last year. He had hypertension and it was not managed. He had stroke. Within a week, he passed on and left a young family. We need, as health professionals, to push the agenda about health screening, about checking our lifestyles, and again, supporting policies that's to do with screening and managing hypertension early. to prevent some of these conditions. And so I encourage every professional out here listening to this to take this on and push the agenda. Thank you very much for listening. Over to you, Victoria.
Thank you very much for my colleague in Ghana, Anema, and thank you for that strong message about addressing the silent killer, hypertension. Indeed, it is a problem. Even here in South Africa, we are starting seeing, it is increasing in the number of mortalities and mobilities. So moving over to South Africa, my name is Victoria, as my colleagues have already mentioned, and I am the country facilitator for Movement Health Foundation here in the country. I will be presenting on the project that is called cervical cancer screening, and it has been recently approved for implementation here in South Africa. So the data that I will present here, I will not present the actual results because we are just starting with the implementation. We are within our initial phase. Thank you. Next slide, please. So just to give an overview on why we chose this project on cervical cancer, on the burden of cervical cancer. Every year, more than 300 women die globally from cervical cancer. And it is reported that 90% of these deaths actually occur in low and middle income countries. In South Africa, to be specific, breast cancer or cervical cancer is the leading cause of death among all the cancer-related deaths in females following cervical cancer or following breast cancer. Hi, colleagues. Can I move to the previous slide? I think we'll need to start. I will just go to the introductory slide. Okay, thank you very much, colleagues. And my name is Victoria Magomani. I am the country facilitator for South Africa for Movement Health Foundation. And I will be presenting the project that has been recently approved for implementation here in South Africa on cervical cancer screening. So just to give an overview on cervical cancer, every year, more than 300,000 women die globally from cervical cancer. It is reported that 90% of these deaths occur in low and middle income countries. In South Africa, to be specific, cervical cancer is the leading cause of cancer-related death and the second most diagnosed cancer among females. We do have a policy that addresses cervical cancer prevention and control, as shown on my left or on my right. And in that policy, HPV vaccination is the primary source of prevention, and screening is the secondary prevention method. Here in the country, screening is indicated every 10 years for the general population from 30 years and above. And for the population that is HIV positive or for women living with HIV, screening is indicated at every 3 years from the time of HIV diagnosis, or even more frequent depending on the initial results of cervical cancer screening. In addition, the World Health Organization has called for elimination of cervical cancer globally, making it crucial for countries to intensify their efforts in addressing this challenge, or curbing the cervical cancer burden. However, in the country, we do have a target of 70% for screenings, but we are performing at an average of 50% across all the provinces, showing that we still have a work to do in terms of cervical cancer screening. We followed the same approach that Ghana followed in terms of roundtable discussions, consultations with the Ministry of Health, with subject matter experts, with oncologists, with program implementers that are working in the cervical cancer space. And we all agree that digital solutions will boost awareness and screening with the ultimate goal of accelerating treatment and prevention options. Next slide, please. So just before I come to the digital solution that we are about to implement here in the country, it is important to note that cervical cancer is highly treatable if caught early, and treatment should start as soon as possible for best results. So at the foundation, we aim to use digital technologies to promote a solution that will be offered at no cost to women, to boost awareness, to address the prevention of cervical cancer, as well as other health information. The digital solution is called Progressive Web App. So just to describe a little bit difference between the native app and the Progressive Web App, the native app is the one that you have to download from your Play Store or from your Google Play. But with the PWA, As long as you have the link and a connectivity or a device that can access the link, you are able to access this information. So that is what we are going to implement here in South Africa. The PWA will contain information on cervical cancer as the disease, just to create awareness and to ensure that people are educated and are aware of the burden of cervical cancer. It will have information on the risk factors, the risk assessment, and also the symptoms of cervical cancer so that women can know when to go and screen. It will have information on HPV vaccination. I've already highlighted that HPV is regarded as the primary preventative action. So it is important that we do also have this information on this app so that women can know, or the general population can know, the importance of having their children screened. Currently, the HPV vaccine project, or the HPV vaccine project, is only for girls that are 9 years and above in school settings. So it is important to have this information here so that parents can actually allow their children to go and screen. It will have information on what to expect on the day of screening so that women can actually know what they are going what will be happening to them when they go to screen, and also to prepare them mentally on what to expect on the screening day. It will have information on pre-counseling and post-counseling that will be AI integrated. We'll also have local screening centers integrated into this solution so that women can actually know the nearest centers to go and screen once they have read and understood why they need to screen. It will have information on post-treatment support depending on the results. Some will be positive, some will be negative. So it will have that information so that women can know the way forward in terms of accessing treatment or making sure that they stay negative in terms of cervical cancer. And we'll have information on partner support as well for those that will be having the disease or living with the disease, to ensure that they are supported within their families, and palliative care as well. So the impact that we are hoping with this solution is better patient outcomes due to early detection. I already highlighted that the early cervical cancer is detected, then even treatment is possible, and it is less costly. We also aim to have a cost or reduction in cost for cervical cancer treatment through early screening, as well as increased value for statistical life. For Movement Health Foundation in particular, the impact is that it will have identified profiles of high-risk populations. We'll have early detection and timely intervention to ensure that women actually receive the treatment that they're supposed to receive. I've already highlighted the challenge that we have in terms of screening, that we are performing below the target of 70%. So this will add to what is already existing to ensure that we expand the screening coverage. And the last is a positive contribution towards cervical cancer elimination. I've already mentioned that the WHO has called for elimination of this disease, cervical cancer. So this will be an add-on towards the effort that the country is already putting towards eliminating cervical cancer. Next slide, please. Just describe the detailed impact here. Some of them I've already mentioned in my previous slide. The better patient outcomes, early detection will ensure that treatment is also available early, and we can hope for the better outcome. There's also enhanced access, so it will empower women with information on when and why they should screen, and locate the screening and referral centers. As I said, there are intervals for screening, 3 years and 10 years for the different populations, but women are just not screening. So this will empower women to actually know when to screen and actually go for the screening. It will also result in equity in access. The primary focus here is for the general population, for all the women in South Africa, but primary focus is on rural and primary urban underserved areas. So it elevates screening rates and expedite treatment access as well to those women that will not necessarily have received their, or have to go to receive their screenings. In terms of health system efficiency, it enhances early stage cancer detection and facilitates timely referrals to suitable healthcare facilities. It will aim to reduce treatment costs, as I've already mentioned, because of the early detection of this disease. We already have a policy that addresses the screenings. It addresses all the prevention pathway that needs to be followed. So we are not coming up with a new policy, but it aligns with what is already existing, but it just addresses the implementation challenges that we have. Next slide, please. So in terms of scaling up this solution, we for the pilot phase or the demonstration phase, we are starting with a few districts in South Africa. We do have 52 districts in South Africa, but we are starting with 3 to demonstrate that this actually works. And after the demonstration or the pilot phase, it will be screened to the entire country, to all the 52 districts. We're not foreseeing any challenges in terms of scaling up. We do understand that provinces are autonomous and some might have delays in implementation, but in general, all provinces will be able to, or all districts will be able to receive this and being scaled up into their respective districts. In terms of other countries in the region, in the sub-Saharan African region, this will also be possible to screen in those regions. The solution might need to be adapted based on the country needs and country resources. For example, availability of devices to actually access the PWA or the connectivity thereof. So the countries might need to adjust this to suit their available resources and their needs, but in general, it should be able to be screened in any region. And then in other regions outside of the Africa region, we also foresee that this will serve as a model to many countries for cervical cancer and other cancers as well. So this will not only be for cervical cancer, but it will also be applicable to other cancers as well, and also to serve the populations that are underserved and in remote settings. So we're seeing that it is scalable here in the country and outside of the country as well. Next slide, please. I have mentioned that the solution or this project has just been approved for implementation. So hence I did not have the example like my colleague had in Ghana where she was showing the solution. So here I don't have the actual PWA because it's still under development. But be that the case, we already learned some lessons through the process that we have undergone thus far. We have learned that stakeholder engagement is key. I've already mentioned that we had to meet with key or with subject matter experts, with key stakeholders from the Ministry of Health, private sector. Everyone is involved in the cervical cancer, in the oncology space. And we found that collaborating early with the stakeholders builds alignment and commitment because there are already solutions or there are already programs that are addressing cervical cancer. So us aligning with them actually made sure that the diverse perspective are incorporated, making the project more comprehensive and improving the likelihood of buy-in from all parties. So buy-in is very important by all or from all stakeholders. And then also to include local stakeholders. So what we found is that here in the country, there's already been approaches or there has already been solutions of similar nature that has been developed at different scales and they have been implemented at different scales. And for us, we do not have to come up with something new or reinvent the wheel. We had to liaise with the existing partners or local partners that have worked on this solution before to make sure that we redefine and expand the efforts that they've already made. So not to come up with something new, meanwhile there's already something of similar nature existing in the country. Also, what we found is that identifying resource, it has to be done at an early stage. So during the proposal development stage, when we were doing stakeholder engagement and meeting with the different kind of stakeholders, we found that that is the best time to evaluate the resources that will be needed, be it financial, human, technical, or other resources that will be required for the implementation of this project. South Africa is a very complex country with a complex healthcare setting. And what we found is that we have to be flexible in terms of adapting to the approach or adapting in our timelines and in our approach of what we thought that this project would be implemented as, especially when working with new technologies or introducing new solutions. We have to make sure that we are flexible when we're able to adapt because things changes and priority changes. And with the different partners involved, we have to make sure that we cater for everyone to ensure that there's buy-in and the sustainability at the end of the Movement Health Foundation involvement. And then in terms of sustainability planning, the country is very specific when it comes to projects on sustainability or that they should be sustainable. So the country at its best interest, they have to make sure that, or we have to make sure, including myself, that projects that come in the country, they are sustainable. They are not only there for the time being or for the time that they are receiving resources. But after we have moved as Movement Health Foundation, the solution should be sustainable to make sure that there's continuity. So we found that we should not leave this at the very end of the pilot phase or at the very end of the implementation. But while we are still meeting with stakeholders, while we are still building the proposal, we have to ensure that we address the sustainability component so that even when we present and we meet with stakeholders, we ensure that we not only discuss the time frame that will be here in the country as Movement Health Foundation, but we also address the sustainability factor. So with those few words, I hope that I was not too fast for you, and I hope that I was able to describe the project that we are about to implement here in South Africa. And if you are here from this country, from South Africa, and you wish to be part of this project, please, you are welcome to reach out to us through the contact platforms that will be projected at the end of the presentation. But again, let us work together to cap this disease that is killing our women here in South Africa, cervical cancer. And we are hoping that once this has been implemented, we're able to move to other diseases that are troubling the country as well. So thank you very much. I will hand over to my colleague who is based in Algeria to give us the project that is currently being run in Algeria. Thank you, and over to you, Adam.
Many thanks to you, Victoria, and to Anima for setting the ground and also proving that Movement Health is a very well organized institution and also have a very innovative approach, not only on the geographical aspect, but also in driving projects that looks to empower the individual, as we've seen in South Africa with empowering women in terms of awareness, in increasing the literacy, empowering the health professional, as we have seen in Ghana as the pharmacist. And in Algeria, and thanks to also Movement Health, we are trying to see if we can empower a structure and impact as the others project also on the policy level. So my name is Adam Selamnia. I'm the country facilitator for Algeria. And when you come on such a ground, you know, and Victoria said that you have to also have become a trust party to the authorities that you liaise with or diverse stakeholders. We don't come on an empty ground in Algeria. Algeria has a Bismarck type health system and has achieved a few years after its independence a universal health coverage. I mean, it has numerous hospitals, has trained numerous, and is recognized for actually a very nice training from its health professionals in diverse specialties. However, in Algeria, like many countries on the continent, they have undergone Algeria has undergone a rapid growth with a multiplication of 4 of its population in 60 years. And Algeria, like many other countries from the north and the south, is also transitioning at the demographical level and also at the epidemiological level. And this lead the country or impede the country to modernize its legacy health system, which has well worked up to now, but now has to work and to prepare itself for the next type of diseases, and also for to integrate the new technologies that is coming and are going to help. So when looking, and that's the focus actually of Movement Health at the NCDs, and this is where we are trying to liaise with the authorities and see how we can have this already nice system improve and go one step, go one extra mile. When we looked at the NCDs, and we unsurprisingly found that, you know, they are the major cause of death, like in Algeria, but now many parts of the world. And actually, they are accounting of 79% of the death, and 14% of them are premature. So that really pushes us to see where we can have a good impact, and obviously in NCDs. And in NCDs, so the CVDs, or cardiovascular disease, are actually very important, and the coronary emergencies actually remain a very important health issue in Algeria, and reducing the delays to intervention from the onset of symptoms to having people going to the hospital is very critical for the survival of the patient. Diverse surveys allow to estimate about 40,000 deaths due to myocardial infarction alone in Algeria, and this figures has doubled over the last 10 years. So there is really a need to best understand the causes and the rise of these diseases and to act upon them as fast as possible. And indeed, with those technologies that have been already discussed and touched upon in Ghana, for example, or in South Africa, but with digital health technologies, we might help, if not stop this increase, but reverse this staggering trend. Next slide, please. Again, we are coming on a very well established floor by the Ministry and the health authorities there, and indeed they have launched already in 2021 the STAMI National Plan Against Myocardial Infarction, and back at that time they started to set a mobile application that was developed to support referring doctors, usually physicians, to the hospitals that are equipped to receive this type of patient undergoing myocardial infarction. And also, the hospitals have started to equip themselves with EMR, electronic medical record, which has been set and developed by authorities. And so there is a scene that is very nicely done, but we were looking at how are there still gaps to be filled in that domain. And indeed, although they already implemented some of these digital technologies, we are saying that the patient is not reaching in the proper setting, the proper timing, to the hospitals. That means within the first 6 hours, due to many issues, to any of the 31 cath labs that are across the countries. So there is a gap there, and this is where we started to look at. Next slide, please. So following a methodology that was provided actually by Movement Health, we gathered national experts from diverse fields who ultimately framed a challenge around digital health. And this challenge proved right, as the authorities chose a couple of months later, after this challenge was crafted, that digitization, or digitization, as we say in Ghana, is a key component of the action plan for the patient roadmap. And with this series of discussions with ministries, actually this challenge led to identify that cardiology was indeed the first choice because of this gap that was identified. So authorities, and in Algeria, they were very keen and open to start discussing, and it is not current that such organizations approach the Ministry of Health to set and to discuss with them how they can improve the system, but they were very keen and open and organized with us the technical audits of their cardiology, of the cardiology and laboratory department in 5 hospitals. Say, okay, you think there is a gap there? So please go and do the technical diligence, and let's see what you come up with. And so after we did these technological audits that were taken in Algiers, we learned a few lessons. First, these audits showed that 70% of patients who were referred to the hospitals were not, it wasn't because of an emergency issue. So people were sent to the hospital, but they could have been treated elsewhere. So this creates a bottleneck at the hospital, and this is really critical when you want to really take care of the ones that needs care as fast as possible. And so second, we found that although there was already an AMR and already an app, there were no integration between them. So there were duplication of data that has to, so a sort of a break in this chain of data between those two systems that was burdensome for the doctor's perspective to recode or rewrite some of the data that were coming from the mobile app. And for us, that was those two key learnings who prepared the ground now as to a project that we will we are starting to discuss with the authorities, is actually to build a system where there would be this integration between the mobile app, where sometimes the doctors, the referring doctors, could have the ECGs, right? And these ECGs arriving directly in the AMR system of the hospital, avoiding then to redo tests that has been done already. Last, I think we suggesting that we could have a better outcome with this integration and showing to the authorities that we can act upon this 70% of people that are coming and not referring, open the ground for the discussion with the authorities, and open the ground with the fact that it would be interesting to add or to implement this within the STAMI national plan that I already touched upon. So as for now, we are now discussing with diverse stakeholders, local ones, and even startups, because there are numerous startups that are coming and blooming in Algeria, to see how we can align a coalition of stakeholders to work on this integration, and have of course, follow the agenda of the authorities according to this plan, to match this plan with this solution. So a decision has been made by the Ministry of Health to set up committees, a steering committee and an implementation committee, and this is the next phase. And within that period where these committees would be actually set in place, we are starting to discuss with a couple of stakeholders to start as soon as possible as those committees will be installed. So with this, I'll leave the floor and give the microphone back to Hector. Thank you very much.
Thank you, Adam. Thank you, Victoria. Thank you, Anima. We have learned the key opportunities that we are working in order to increase awareness for screening in South Africa, increase referral to consultation in Ghana, and accelerate the time from diagnosis to effective treatment, while at the same time learning from what you have shared, Adam, of the opportunity as well to better diagnose those cases that really need to a referral to a specialized treatment center. We are looking forward to continue scaling these interventions and learning together with the health ecosystem in Africa and around the world on how we can tackle the triple crisis that health systems are facing, where digital health has a key role to play. So we invite you to follow us in our social media to continue strengthening this community that can present the biggest single most relevant opportunity to give a comprehensive response to the needs that patients are needing now and in the future to have effective treatments to guarantee healthy lives. Thank you for following us. Keep tuned. Bye-bye.
Bye-bye.